So within the next 10 seconds, sir, we will be live.
Sure.
So the 3, 2, 1. So we are live now. We can start the session. Sanket, sir, over to you.
Thank you. Good evening, everyone. I welcome one and all to ProCare AHT's Midlife CMEs, a scientific platform provided by McLeod's Pharmaceuticals. I am Dr. Sanket Newale, representing medical affairs at McLeod's. And today, we all are gathered here to listen from an eminent speaker on the topic dapagliflozin beyond bridging the gap in heart failure management with or without diabetes. A bit about the company. McLeod's is equipped with an experience spanning across 3 decades, has emerged as a global force with a dedicated team of around 14,798 professionally qualified employees worldwide and state-of-the-art manufacturing and R&D setup. We are one of the fastest growing pharmaceutical company in India. With a growing pace presence in more than 80 countries, McLeod's is now gearing to be a pace setter for the world healthcare. And the eminent speaker I've been referring to is none other than Dr. Vinit Kumar. Sir has done his MBBS from Darbhanga Medical College and Hospital. He has done his MD Medicine from VMMC, Safdarjung Hospital, New Delhi, and then has gone into DM cardiology course and has finished it from Government Medical College, Thiruvananthapuram. He has worked as an associate professor in the Department of Cardiology, Government Medical College, Thiruvananthapuram. He has presented multiple research papers as well as poster presentations and has gone through intense fellowship and various workshops. Without any further ado, I would like to welcome Dr. Vinit Kumar and request him to start his session. Over to you, sir.
Very warm good evening to everyone. Thank you, Dr. Sanket, for such a nice introduction. And I also want to say thanks to the McLeod for giving the opportunity to share my views and opinions regarding this is such important molecules, dapagliflozins. First, we'll see what is heart failure. Heart failure is a severe failure of the heart to pump enough blood around the body, and the symptoms usually breathlessness, fatigues, and lymphedema. If we see with this heart failure, quality of life as well as survival is very poor. If you see within next 5 years, almost half or more than half of the heart failure individuals is usually not surviving. So mortality, we can say almost 50% in 5 years. If we see the global burden of heart failure, it's rising day by day. Right now, we can say 26 million heart failure patients is there in the worldwide, and it is very much more than 37.7 million is undiagnosed cases. That is actually more than whatever we are seeing in our daily routine clinical practice. More than 50% of individuals are rehospitalized for heart failure within 6 months of discharge. So that figure is itself depicting what is the morbidity or what is the life quality of that individual patients. And its heart failure is the number one cause for hospitalization worldwide. If we see the incidence of heart failure in individual with or without diabetes mellitus, Framingham Heart Study, it's very large study. that is telling in male, diabetic male 7.6 per thousand, but in women it is 11.4 per thousand. It's less relatively non-diabetic male, it is relatively less, half only. Other study, cardiovascular health study, that number was very much more compared to that Framingham study. Diabetic male, that was 44.6, and female it is 32.5 per 1000. And that enhanced study, diabetes male, it is there usually we are calculating 65.5% chance of developing heart failure, and women also it is almost equally 61.8%. If we see the renal disease, kidney disease, it's almost 850 million people worldwide have the kidney disease. If you see the death each year due to CKD, it is 2.4 millions. And diabetes and hypertension is responsible for almost 75% of CKD. And if it is very, very surprising, 90% of CKD people are unaware that they have CKD or they have some renal problem. If you see the prevalence and manifestations of renal disease in diabetic and non-diabetic populations, it's very well known. It's very, very common in diabetic compared to non-diabetic, either all forms of kidney disease or albuminuria or impaired GFR, or both impaired GFR and albuminuria. That enhanced study is telling the prevalence of CKD in diabetic, it is almost 42.3%. And all-cause mortality 10 years with diabetes, it is 19.10%, and without diabetes 8.60%. If you see that diabetes and heart failure are linked, so their management should also be linked. Who have diabetes characterized by elevated blood sugar levels are 2 to 4 times more likely to develop heart failure than someone who did not have diabetes. But heart failure is a condition in which heart fail to efficiently pump oxygenated blood through the body, and it's also a risk factor for diabetes mellitus. So both disorders are characterized by insulin resistance and high level of inflammations. So these both diabetes and heart failure are very much linked to each other. If you see their 6-year CHF incidence among 1,000 person year by the age group, it is all the age group, diabetics have very much higher compared to non-diabetes, and their rate ratio is very much significantly depicting that statements. In all the age group, heart failure is very, very much common in diabetics compared to non-diabetic. Diabetes, heart failure, and renal dysfunctions, it's a vicious cycles. Diabetes mellitus, it's a major risk factor for the heart failure, and heart failure itself will intensify the severity of diabetes. Diabetes again is a risk factor for the CKD or the renal damage, kidney disease. And the kidney disease will intensify the heart failure, and heart failure will lead to the CKD kidney disease. And both the kidney disease and heart failure will lead to sodium retention that will lead to the peripheral edema. Basic etiology is the insulin resistance that is developing either due to the obesity. So after insulin resistance, there is a insulin hypersecretion, and then it leads to pancreatic insufficiency and followed by decreased insulin secretion. In spite of insulin resistance, insulin secretion is going to be less. That will lead to hyperglycemia, and hyperglycemia, again, they will go for the macroangiopathy, that is large vessels involvement, either into the form coronary artery disease or renal artery stenosis or limb arterial stenosis, peripheral arterial stenosis. That will lead to glycation of the molecules, and again that will increase the inflammations. If it is due to macroangiopathy and coronary artery disease, that will lead to myocardial infarctions and followed by decreased left ventricular ejection fraction. That will lead to heart failure with reduced ejection fraction. In the other way, if there is sarcomere stiffness, that will lead to heart failure with normal ejection fraction. So both type of heart failure, either with reduced ejection fraction or normal ejection fraction, can be caused by diabetes. And after the heart failure, it will lead to activation of renin-angiotensin systems and sympathetic activation. Renin-angiotensin system activation will lead to retention of sodium and water, and sympathetic activation will lead to lipolysis. Again, it will increase the lipogenesis. Gluconeogenesis, again, it will increase the insulin resistance. So it's ultimately becoming a vicious cycle that will leading to worsening and worsening of diabetic conditions. If you see the diabetes, whatever we have seen in the last slide, it's almost the same thing, only diabetes, hyperglycemia, insulin resistance, and hyperinsulinemia, inflammation, dyslipidemia, endothelial dysfunctions that lead to coronary arterial disease or ischemic cardiomyopathy. Ischemic cardiomyopathy will lead to heart failure with reduced ejection fraction. And in the other way, it might causes cardiomyocyte hypertrophy or left ventricular hypertrophy that will lead to diabetic cardiomyopathy, or that will lead to renin-angiotensin activation, fibrosis, and autonomic dysfunctions. Ultimately, in both ways, it will cause heart failure in diabetes mellitus. If you see the heart failure in diabetes mellitus, what is the therapeutic approach? What we have available? We have commonly used some molecules that we all know very well, like biguanide, sulfonylurea, thiazolidinediones, GLP-1 receptor agonist, DPP-4 inhibitor, SGLT2 inhibitor, and insulins. It's acting on different molecules that we'll see in the letter. And we have some other potentials molecules can become available in near future. Like we can alter the myocardial substrate metabolisms. We can change the mitochondrial bioenergetics. We can change the oxidative stress, lipotoxicity, inflammation, ER stress, insulin signalings, beta-2 adrenergic receptor signalings, GRK2 signaling, renin-angiotensin aldosterone signaling, autophagy, or acetylations. Diabetes is the omnious current available therapy. We all know very well. Hyperglycemia is the result of lot of mechanisms like impaired insulin secretion, that will be, or increased glucagon secretions, or increased GP, decreased glucose uptake by muscles, increased glucose reabsorptions in the renal systems, increased lipolysis, or decreased incretin effect. And all the oral anti-diabetic drugs or insulins are working on these mechanisms only. We need not to go for detail of other molecules we all are using in our day-to-day clinical practice. Effect of diabetes mellitus treatment on risk of the heart failure. If we see their insulins, there is no definitive CV outcome trials examining in heart failure. If we see the GLP-1 receptor agonist, there is no increases in the risk in heart failure or hospitalization for heart failure. That means we can say this molecule is almost neutral. So modest improvement in ejection fraction in heart failure is seen in the sum of the study. Metformin decreases mortality in heart failure patients, decreases reduced cardiac hypertrophy, better short-term and long-term prognosis in patients with heart failure. If we see their other molecule, thiazolidinediones, fluid retention and weight gain is a side effect, and particularly Its use in NYHA function class 3 or 4, especially we should not use in the worsening heart failure. SGLT2, it will improve the CEB risk factor, weight reduction, reduction in systolic blood pressure, reduction in CV mortality and hospitalization from the heart failure. If you see the DPP4 inhibitor, there is no increases in risk in heart failure. That is, it is the CV neutral. So now we see the what guidelines is recommending for the oral antihypertensive, oral anti-diabetic drugs. First line, it's the ADA recommendation that is recently came. First line therapy, they are recommending metformin with the comprehensive lifestyle, including weight management and physical activity. That is very, very important. Now we'll see indicator for high risk or established ASCVD, CKD or heart failure. If it is there, either it is established ASCVD, CKD or heart failure, you have to consider independently of the baseline A1C or individualized A1C target. If it is ASCVD as the main disease, establish ASCVD or indicator for high ASCVD risk. GLP-1 receptor agonist with the proven CVD benefit or SGLT2 inhibitor with the proven CVD benefit if GFR is adequate. And if we cannot able to achieve the HbA1c, our goal target, if the further intensification is required or the patient is now unable to tolerate GLP-1 receptor agonist or SGLT2, choose agents demonstrating CV safety. For the patients on GLP-1 receptor agonist, consider SGLT2 with the proven CVD benefit or DPP4 if not a GLP-1 receptor agonist or basal insulin or thiazolidine disulfonylurea. But in the otherwise, if the heart failure or CKD is the main established thing, particularly heart failure with reduced ejection fraction or CKD, specifically eGFR is less, that is 30 to 60 ml per minute, we have to use SGLT2 inhibitor with evidence of reducing heart failure or CKD progressions, or SGLT2 inhibitor not tolerated or contraindicated, or if eGFR is less than adequate, then GLP-1 receptor agonist with the proven CVD benefit. If the A1C is not achieving, then we have to, in this group only one difference is there compared to earlier. We have to avoid TZD in the setting of heart failure and choose agent demonstrating CV safety. For the patients on SGLT2 inhibitor, consider adding GLP-1 receptor agonist, or we have to add DPP4 inhibitor. We can give basal insulin or sulfonylurea. So this ADA guideline is recommending if ACVD is the main feature predominant, then we have to use either GLP-1 receptor agonist or SGLT2 inhibitors should be preferred. But if heart failure or CKD predominant, SGLT2 inhibitors should be preferred. If compelling need to minimize hypoglycemia, DPP4 inhibitor, GLP-1 receptor agonist or SGLT2 inhibitor, TZ2 should be preferred. If compelling need to minimize weight gain or promote weight loss, GLP-1 receptor agonist or SGLT2 inhibitor should be preferred. On the other way, ADA or ESD update 2019, it's also telling the almost similar things. If ASCVD is predominant, GLP-1 receptor agonist or SGLT2 inhibitor should be preferred. But if heart failure or CKD predominant, SGLT2 inhibitor should be preferred. And everything is almost similar according to the ADA guideline. Impact of glucose lowering medications on the cardiovascular endpoint in the cardiovascular outcome trials and heart failure hospitalization. If you see there, other than SGLT2 inhibitors, only SGLT2 inhibitors like empagliflozin and in the IMPA-REG outcome trial and canagliflozin in the CANVAS trial have demonstrated decreased risk in the cardiovascular death, MI, or a stroke. Molecules have demonstrated such a significant reduction in the risk. If you see in the GLP-1 agonist, there is no difference in the risk among lisinotypes, liraglutides, semaglutides, or exenatides. In the DPP-4 inhibitor, saxagliptins, that's TME 53, have demonstrated increased risk of heart failure. That should be avoided. In the case of heart failure, we have to choose among CV neutral. So sitagliptin and elogliptin have shown there is no difference in the risk. If you see the major adverse CV events, MACE is definitely less with empagliflozin and the canagliflozin that is favoring for benefit, and for the as well as for the heart failure hospitalization also, these two molecules have shown significant benefit. Only saxagliptin have shown worsening heart failure hospitalizations. Clinical consideration for SGLT2 inhibitor from the ADA and AHA. If you see the ADA or ESD, for the patients with or without established atherosclerotic CVD, but with heart failure with reduced ejection fraction or CKD, the level of evidence for benefit is greatest for SGLT2 inhibitor. SGLT2 inhibitors are recommended in the patients with diabetes mellitus and heart failure, particularly those with heart failure with reduced ejection fraction to reduced hospitalization for heart failure, MACE, and CV death. And SGLT2 inhibitors are recommended to prevent the progression of CKD, hospitalizations for heart failure, MACE, and CV death in the patients with diabetes mellitus with CKD. Even the AHA, American Heart Association, is also telling this. Similarly, combined with significant reductions in cardiovascular and all-cause mortality seen with SGLT2 inhibitors, it is reasonable to consider SGLT2 inhibitor as a part of prevention strategy with the diabetes mellitus at a high risk for heart failure. And SGLT2 inhibitor are also good glucose lowering medication choice in the patients with established heart failure and diabetes mellitus. This class appear promising for treatment of established heart failure in the patients without diabetes mellitus. It's very, very important. SGLT2 inhibitor bridging the missing link in the cardiorenal syndrome with or without diabetes mellitus. There is a key unmet need in the management of cardiorenal syndrome. If you see the heart failure with reduced ejection fraction, despite the availability of several molecules with established efficacy in the heart failure with reduced ejection fraction, mortality rate remain unacceptably high. Some study is telling 5-year mortality rate is approaching almost 75%. Few patients with heart failure reduced ejection fraction treated with recommended dose of evidence-based medicines. If you see some study, ACE inhibitor and beta blockers have provided less than 1/4 of individuals, beta blocker and ACE inhibitor, 22% and 12% respectively. This is very, very bad scenario. All heart failure patients should be on guideline recommended optimal dose of medical therapy, especially those drugs known for reducing in mortality. Heart failure with normal ejection fraction, preserved ejection fraction, no treatment options have been identified to date for heart failure with normal ejection fraction. Treatment is reliant on the management of comorbidities and symptoms only. Cardiorenal syndromes, no treatment have been identified that provide sufficient cardiovascular and renal benefit. RAS inhibitor and diuretics can be beneficial, but can also worsen renal function. So we did not have any definite options. cardiorenal efficacy of newer anti-hyperglycemic drugs in either primary or secondary prevention. Diabetic population, for these three molecules we are comparing: SGLT2, GLP-1 receptor agonist, or DPP-4 inhibitor. If you see there, primary prevention of diabetes multiple risk factor, MACE is neutral in all these three molecules, but heart failure and CKD is less with SGLT2 inhibitor and neutral in other two. But for the secondary prevention, SGLT2 inhibitor is known to reduce the MACE also, as well as heart failure and CKD. In GLP-1 receptor agonist, it reduces the MACE in secondary preventions, but it's neutral in heart failure and CKD, and DPP-4 is neutral in all these 3 points. Let us see some example. One 68-year-old woman at high risk for heart failure with diabetes mellitus, hypertension, dyslipidemia, and known coronary artery disease. Renal parameter is okay. Creatinine is 1.1. eGFR is 55 ml per minute per 1.73 meter square. So now what may be the glucose lowering medication options? Metformin, SGLT2 inhibitor may decreases risk of cardiovascular event and heart failure hospitalizations due to multiple risk factors like diabetes, hypertension, dyslipidemia, and CAD. GLP-1 receptor agonist may decrease the risk for cardiovascular event. We have to avoid TZD. That may increase the risk for heart failure. And DPP-4 inhibitors, sulfonylurea, and insulin should be considered only if unable to achieve adequate glycemic control with alternative options because they are severe neutral. If we see the next case, that is 78-year-old man with diabetes, recently diagnosed a stage C heart failure with reduced ejection fraction. It is caused by non-ischemic cardiomyopathy. Ejection fraction is very less. Renal parameter is okay. Now, we have the options of metformin and SGLT2 inhibitor that may decrease the risk of heart failure hospitalizations. TZ thiazolidinediones is contraindicated in heart failure, especially we are saying a stage C, symptomatic. We have to avoid DPP-4 inhibitor because some may increase the risk of heart failure hospitalizations. Avoid GLP-1 receptor agonist if recent heart failure decompensation is there. Sulfonylurea and insulin should be considered only if unable to achieve adequate glycemic control with metformin and SGLT2 inhibitor. Next case we'll see 59-year-old man with diabetes and recently diagnosed a stage C heart failure with normal ejection fraction. EF is normal, 60%. Renal parameter is okay. Again, we have the option of metformin and SGLT2 inhibitor that may decrease the risk of heart failure hospitalizations. That is very, very important. Again, we cannot use TZD because that is contraindicated in symptomatic heart failure, especially in the NYHA class 3 or 4. And we have to avoid DPP-4 inhibitor because some may increase the risk of heart failure hospitalizations. Fourth case is 72-year-old woman with diabetes, stage C heart failure with reduced ejection fraction caused by ischemic cardiomyopathy. EF is less. Renal parameter is worsened. eGFR is less only 25. In this scenario, we have the best option of using insulin. Again, TZD are contraindicated. Metformin should not be used if eGFR is less than 30. Trials of SGLT2 inhibitors on eGFR, lesser eGFR is ongoing, but now should not be used if eGFR is less than 30. So SGLT2 inhibitor recommended as the potential management option for heart failure with or without diabetes mellitus. If we see the American Diabetic Associations or AHA, they also recommending oral anti-diabetic class recommendation with the latest guidelines. And for the heart and renal part, the only class with the cardiorenal benefit with or without diabetes mellitus. And this SGLT2 inhibitor is the first oral anti-diabetic class to reduce the CV mortality and heart failure risk. So we can tell, or we can say, SGLT2 inhibitor is bridging the gap in heart failure management with or without diabetes mellitus, because it's the oral anti-diabetic drugs, but it reduces hospitalizations. Kidney and glucose homeostasis. Kidney is involved in regulation of glucose homeostasis via three different mechanisms. Release of glucose into the circulation via gluconeogenesis. Uptake of glucose from the circulation to satisfy the energy needs of the organ itself. And reabsorption of glucose into the circulation from the glomerular filtrate to conserve glucose. SGLT2 inhibitor and glucose managements. SGLT2 inhibitors affect multiple sites in diabetic kidney. Novel insulin-independent mechanism of reducing renal tubular glucose reabsorption, reducing a reduction in blood glucose without stimulating insulin release. It inhibiting the molecule sodium glucose transporter, so it will reduce the intake of glucose from the lumen to the cell. So SGLT2 inhibitor enhance natriuresis and causes intravascular volume contractions and alter intrarenal hemodynamics, which likely contribute to beneficial effect on blood pressure, body weight, as well as albuminuria. This pleiotropic effect have translated into reductions in cardiovascular event and preservations of kidney function in large cardiovascular outcome trials. If we see their clinical findings, it decreases the glucose level in the plasma, it decreases the body weight, it decreases the blood pressure, decreases plasma uric acid level, decreases glomerular hyperfiltrate. SGLT2 inhibitor cardio and renal. SGLT2 inhibitor, it is increasing the excretion of glucose, so it causes glycosylturia, as well as it increases the natriuresis. As it causes the glycosuria, it causes negative caloric balance that lead to decreases in the total body mass or total body fat mass. It decreases epicardial fat, increases cardiac contractility, decreases inflammation and fibrosis. As it causes glycosuria, it decreases the blood glucose level, so lead to reduction in HbA1c level. It lead to reductions in inflammations and glucose toxicity that is beneficial, both cardio as well as renal. Uricosuriya decreases plasma uric acids, that will decrease the atherosclerosis. Natriuresis causes reduction in blood pressure, decreases in arterial stiffness. Natriuresis lead to increased tubuloglomerular feedback. So it decreases intraglomerular hypertension or hyperfiltrations, decreases plasma volumes, decreases myocardial stretch. So it leads to decreases in ventricular arrhythmias. So no sympathetic nervous system activations. These ultimately lead to cardiac and renal protection. Cardioprotection decreases cardiac afterload as well as preload. Increases myocardial oxygen supply, increases cardiac systolic and diastolic functions, and decreases in MACE risk of heart failure. Nephroprotections, we are telling, it lead to decreases in intraglomerular pressure, decreased blood pressure, decreases progression to CKD. it's almost the same thing whatever we have seen in the last slide. It decreases glucose level, glucotoxicity, decreases plasma volume, increases hematocrit and hemoglobin, decreases systolic blood pressure, decreases arterial stiffness, improve cardiac fuel energetics, increases weight loss, decreases adiposity, and decreases inflammation. And their benefit, cardiorenal protection is beyond the glycemic control. Sodium glucose cotransporter 2 inhibitor is the cardiorenal protection mechanistic overview. 2 inhibitor is leading to natriuresis and glucosuria. Glucosuria will lead to glycemic control and weight loss. Other than glycemic control, natriuresis will lead to tubuloglomerular feedback, intraglomerular pressure reduction, blood pressure lowering, and ameliorations of volume overloads. Other than that, recent result in non-diabetic experiment in CKD model, it decreases oxidative stress, decreases fibrosis, decreases local inflammation, decreases tubular senescence, and decreases glomerular damage. That will lead to renal protection beyond decreases in blood glucose or serum glucose level. Mechanistic rationale for investigating SGLT2 inhibitor in heart failure beyond diabetes mellitus. Rationale for exploring SGLT2 inhibitor for the treatment of heart failure in the patients without diabetes mellitus. Diabetes and heart failure have similar pathophysiological feature as we have seen in earlier slides. There is endothelial dysfunctions as well as insulin resistance in both diabetes as well as in the heart failure. Mechanistic effect of SGLT2 inhibitors are seen in the patients with or without diabetes. Diuretic effect as well as metabolic effect. Diuretic effect is due to natriuresis and glucosuria. And increased ketone bodies. And CV benefit of SGLT2 inhibitors are largely independent of glucose levels. But all SGLT2 inhibitors are not same. Journey of dapagliflozins beyond glycemic control. Indication in the patients with diabetes mellitus to reduce the risk of heart failure, MACE, and CV death. Primary prevention populations, reductions in the heart failure hospitalization is seen with dapagliflozins, as well as in secondary preventions with established CV disease also. MACE reduction and CV death is seen in secondary prevention with the canagliflozins and empagliflozins. Declared trial was with dapagliflozins. Dapagliflozins is the one cardiovascular outcome trials with a major primary prevention patient, that is high risk patient without established ASCVD. If you see there in declared trials, it was almost 60% of the individuals were without established ASCVD. And other way, canagliflozin trial, that was canvas trial, it was almost 1/3 only, while in the IMPAREC, that individual populations was very less, it is 1%. So this is the first and only FDA approved SGLT2 inhibitor for the patients with heart failure with reduced ejection fraction with and without diabetes mellitus. There is no other SGLT2 inhibitor is indicated to reduce the CV death in the patients with heart failure with reduced ejection fraction with or without diabetes mellitus. Dapagliflozins offer a novel pathway that complement current therapies for heart failure with reduced ejection fraction. If you see there in the renal, glucose sodium reabsorptions, it increases glucose excretions, increases sodium to distal tubules, and increase urine production. And that will lead to decreases in the plasma glucose level. In the circulation, it will lead to decrease in the plasma volumes and decreases in systolic blood pressure. In the heart, that will culminate into the heart pressure under which the heart fill, that is preload reduction, resistance against which the heart have to eject the blood, that is afterload. If both preload and afterload will reduce, that result will reduce to reduction in heart failure hospitalizations and the neurohormonal effect of down regulation of elevated sympathetic activity. Ultimately, that will lead to down regulation of sympathetic activity, reduction in the preload and afterload, and improved survival in heart failure with reduced ejection fraction. Dapagliflozin approved indications: diabetes mellitus, adjunct to diet and exercise to improve glycemic control in the patients with diabetes mellitus, reduce the risk of hospitalization for heart failure in the patients with diabetes mellitus, and establish CVD or multiple cardiovascular risk factor even without established CVD. In heart failure patients, it is indicated to reduce the risk of cardiovascular death and hospitalization for heart failure in adult with heart failure with reduced ejection fraction. Doses in diabetics, recommended the starting dose is 5 mg orally once daily, then taken in the morning with or without food. In the patient tolerating 5 mg once daily who require additional glycemic control, the dose can be increased to double. To reduce the risk of hospitalization for heart failure in the patients with diabetes, an established CVD or multiple CV risk factor, recommended dose of dapagliflozin is 10 mg once daily. In the heart failure also, the recommended dose is same, only 10 mg once daily. Yes, we have seen earlier also MACE, heart failure, and CKD. In both, they have divided into either secondary or without established CVD. Dapagliflozin is either neutral in reduction of MACE, but it reduces the heart failure in both either secondary or without established CVD, or it reduces the CKD in both primary or secondary. Dapagliflozin in the patients with heart failure and reduced ejection fraction, that is DAPA-HF trial. It was published in NEJM in November 2019. Objective was to evaluate the effect of SGLT2 inhibitor in the patients with established heart failure and the reduced ejection fraction, regardless of the diabetes is present or not present. That means only for the heart failure. It was randomized phase 3 placebo-controlled trial, NYHA function class 2 to 4, heart failure, reduced ejection fraction, dapagliflozin as given in 10 mg. And their endpoint was composite of worsening heart failure hospitalizations or an urgent visit, resulting in intravenous management therapy for heart failure or the cardiovascular death. If you see there, all four graphs. First was primary outcome. There is significant difference, and this difference is statistically very, very significant. Second graph is indicating hospitalizations for heart failure. Again, we are seeing that blue line is very much different and lower compared to the red line. Death from the cardiovascular causes is also different, and death from any causes is also we are getting difference. Among individuals with heart failure and a reduced ejection fraction, risk of worsening heart failure or death from the cardiovascular causes was lower among those who received dapagliflozin than among those who received placebo, regardless of the diabetes mellitus status. Dapagliflozin helps save lives by significantly reducing CV death or hospitalization for heart failure. Now we will see DAPA CKD study, dapagliflozin in the CKD. Again, it was an exam article. Objective was to assess whether treatment with dapagliflozin compared with placebo reduced the risk of renal and CV events in the patients with CKD with or without diabetes mellitus and who are receiving a standard of care including a maximum tolerated dose of AC neutral ARBs. Number was sufficient and their endpoint was composite outcome or eGFR decline in stage kidney disease, renal or CV death. Secondary outcome, composite outcome of sustained more than 50% eGFR decline in the stage CKD or kidney disease or renal death, CV death or hospitalizations for heart failure and all-cause mortality. If you see their outcome, among individuals with CKD, regardless of the presence or absence of diabetes status, risk of a composite or a sustained decline in estimated GFR of at least 50% in the stage kidney disease or death from renal or cardiovascular causes was significantly lower with dapagliflozin arm compared with other. If you see the albuminuria lowering effect of dapagliflozin alone and then combinations with saxagliptin and effect of dapagliflozin and saxagliptins on glycemic control in the patients with diabetes and CKD, DELIGHT, that was randomized double-blind placebo controlled trials. Dapagliflozin with or without saxagliptin given in addition to ACE neutral ARBs treatment is a potentially attractive option to slow the progression of a kidney disease in the patients with diabetes mellitus with moderate to severe CKD. Dapagliflozin versus placebo in the patients with diabetes mellitus and moderate renal impairment, that is DRIVE study. Adjusted mean change from the baseline in eGFR during 24-week treatment period and 3-week follow-up period. The finding of this study support the positive benefit or risk profile of the dapagliflozin for the treatment in the patients with diabetes mellitus and CKD stage 3A. Red trial, renoprotective effect of dapagliflozin. This trial demonstrated the SGLT2 inhibitor dapagliflozin lower mean GFR beyond glucose controls on top of a standard care, including RAS inhibitor in metformin-treated diabetes without overt nephropathy. Although this study numbers is very less. Clinical trial expand the population that benefit from SGLT2 inhibitors. SGLT2 inhibitors, patients with diabetes mellitus initially that improve the glycemic control. Then that patients without diabetes mellitus also, that is beyond benefit beyond the glycemic control, heart failure reductions in the renal eGFR more than 25 and albuminuria more than 20 milligram per grams. That emperor reduced and DAPA-CKD clinical trial saw that SGLT2 inhibitor reduced hospitalization for heart failure and the occurrence of hard kidney endpoint in the patients with or without diabetes mellitus, demonstrating that organ protection is due to factor beyond glucose lowerings because it's working or giving benefit in non-diabetic population also. Therefore, comorbidities inherent in the cardiorenal syndrome is alleviated with the use of SGLT2 inhibitors. Dapagliflozin, future is bright. Does dapagliflozin does what really want any drugs to improve the symptoms, improve the survivals, and reduce the hospital admissions. And it's working in all these three. We are getting the benefit in all these 3 points. More than 80 trials ongoing beyond glycemic controls. Some study is ejection fraction of heart failure, reduced ejection fraction. Some is showing it reduces the heart failure readmissions. Dapagliflozin's an effect on cardiovascular event in acute heart failure, thrombolysis in myocardial infarctions, head-to-head comparisons of empagliflozins and dapagliflozins. Efficacy and safety of dapagliflozin in acute heart failure is also evaluating. Diabetic patients with decompensated heart failure, and there is many more. So we can say very well, dapagliflozins is bridging the gap, what we are expecting or what we have seen in the earlier slides. SGLT2 inhibitor class recommended by reputed bodies and it's advised by leading guidelines like ADA, ESD, ACC/AHA in the management of diabetes mellitus with ASCVD, heart failure or CKD for reducing hypoglycemia and weight gain. Dapagliflozin was the first and only FDA approved SGLT2 inhibitor for the patients with heart failure and reduced ejection fraction with and without diabetes mellitus. No other SGLT2 inhibitor indicated to reduce CV death in patients with heart failure with reduced ejection fraction with or without diabetes mellitus. We have so many randomized controlled trials and so many studies is ongoing that will again prove the role of dapagliflozin in glycemic control and beyond. Landmark CVOT trials like DAPA-HF have shown survival benefits in the heart failure with much needed molecules bridging the gap of heart. Any question, please?
Thank you, sir, for the wonderful and the crisp session that you gave right now. And I'm sure there would be a lot of questions that would come in the chat box. I would request all the participant attendees to, use the chat box to ask any question to Dr. Vinit Kumar, and sir will answer your questions comprehensively and precisely. Sir, until the questions start popping up, would you, with your kind permission, sir, can I ask you a few questions?
Yeah, please.
Thank you, sir. Sir, when it comes to dapagliflozin and your experience with heart failure patients who are not diabetic, how is your experience and what are the things that you have seen benefits and risk accordingly, sir?
For heart failure patients, we are mainly worried for readmission, heart failure hospitalization. It is a very big issue because the same patients is usually coming every 1 month or just like we are telling 3 months. either due to drug default or with some infection or some increased water intake or like that. And it is very, very, because it's not one individual, one whole individual family is going to suffer with that things, that entity. It, because if one patient is hospitalized, that means whole family will be disturbed. Their schedule is going to be harmed. So it's very, very sure it decreases the heart failure rehospitalization. That is very sure, and we are seeing in a very less time only. And
Lovely, sir.
if we can decrease the heart failure rehospitalization only, even if we can leave the mortality part, that heart failure rehospitalization itself will leading to a very big impact on that morbidity part, or whatever we are telling, quality of life. That is very, very important for a heart failure individual, because they are usually very much, because just after some time they have to come to hospital. That is their usual schedule.
Okay, sir. Sir, about this, they say with dapagliflozin, there is a good amount of weight loss also that happens. Does it happen in heart failure patients as well?
Yeah, because some weight loss we are seeing, because as we are seeing with other diuretic also, because if you are using some diuretic, and we are usually checking the weight daily in the hospital also to see how much it is working, and symptom is improving, weight is reducing, that means we are seeing everything is going in good way. So similarly we are seeing here also, it is also a type of glycosuric and natriuresis that will lead to diuresis also. So we are seeing the weight loss part.
Okay, sir. So coming to the same context, sir, in a heart failure patient, the standard of care itself has diuretics as a part of it. And then when you add dapagliflozin, there is more diuresis or natriuresis that happens. And we can't really load the patient with a lot of water, and we cannot get him into dehydration. So what is your, what is your protocol in balancing this act, sir?
No, if you are starting this molecule, we need to decrease the usual diuretic dose, uh, because anyway diuretic will not going to decrease the mortality. It is only for the symptom relief, and we want to give as minimum dose of diuretic as possible, because as that individual is stabilizing, their symptom is improving, we are usually trying to decrease the dose of diuretic, and this molecule again help us to decreasing the dose of diuretic again further compared to earlier stable dose.
Lovely, sir. And sir, how do you balance? Like you just reduce the dose of diuretic, and any counseling that you would require for the patient, anything that you do, which our cardiologist friends who are attending would really get benefit out of your recommendations, sir.
I did not get what
So in heart failure patients, you cannot increase the fluid load or ask him to have more water. At the same time, when you have standard of care, you have diuretics in the portfolio, and this diuretics would cause water loss, and dapagliflozin also would cause water loss, leading to dehydration. So I'm sure there would be some protocol that you would manage. That the patient doesn't go in dehydration, neither goes in fluid overload.
It's very, very unlikely, very, very unlikely ki heart failure, individuals will dehydrate, because we are usually worrying with overhydration. It's very rarely we are seeing there is a dehydration in heart failure patients, uh, because after a certain time, there is a fluid, that countervalence mechanism is start working, and it's very, very rare entity that individual will go into the dehydration, because once we are starting this molecule, we are usually reducing the dose of diuretic somewhat, and that will definitely itself take, because we cannot ask that individual to take more water, because that will be devastating. That after that we cannot able to do anything, because if that individual water intake will increase, no diuretic or nothing can able to control their symptoms. So intake restriction is very, very important, and it's very, very unlikely it will go into the dehydration. that I have not
Thank you,
seen.
sir. I think this would clear a lot of doubts in the budding cardiologists as well as your mentees who are listening to you today. Would that even though there is a natriuresis or a diuresis that happens with dapagliflozin, we really need not worry on that part. Rather, the benefits of dapagliflozin can be, the patient would enjoy for a longer duration and have better outcomes and reduce its heart failure hospitalization episodes also. Sir, there are no more questions coming in the chat box. So I think I would officially thank you, sir, for the wonderful and the enlightening session. I'm sure the listeners would have gained a deep insights in managing the patients better using the learnings from your session. So we at McLeod's would like to honor your vast experience and your kind heart to share the same on such a platform for the benefit of all the current and the future listeners. I, Sir Dr. Sanket Newale, representing medical team at McLeod's on behalf of the marketing and the sales team. I would like to thank you for supporting us in this endeavor, and I wish you a great day ahead, sir. Thank you.
Thank you. Thank you.
Thank
And
you,
good
sir.
night to everyone. Thank you.
Good night.
So thank you, sir. From here, I am ending the meeting.